Nursing leadership during financial crisis is our episode topic. Our primary guest is Peter Chadwick, a managing director in BRG's corporate finance team. Peter's work history as a CEO, COO, and CFO has positioned him well into his current expert role of improving underperforming healthcare businesses and advising debtors and creditors in complex financial matters. Rejoining the podcast series for this episode is Bill Orrell, a registered nurse and managing director of BRG's clinical transformation team. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Bill, congratulations. You are our first repeat guest on our episode series. Congratulations on having that high honor. Welcome back.
Thanks for having me back, Nick.
And Peter, you have a distinct honor of being not only our first non-nurse, but our first non-clinician. So welcome to the podcast series. Great to hear from you today.
Thanks, Nick. I'm honored.
Peter, before we get into our topic today of managing through financial crises, can you tell us a little bit about yourself, your work, and how you made it into more of the healthcare sector in recent years?
I've been in financial restructuring advisory since 1998. And we work with companies that are in some level of financial distress. So that means they have some liquidity issues, so they don't have enough money to continue operating for an extended period of time, or they have significant operating issues. They're operating at a material loss and need to address that loss. Usually it means that they've tripped the financial covenant, and so they have to address their operating profile in order to get back in good stead with their lenders. I spent the first decade or so of my career working in manufacturing, particularly in automotive, culminating with advising Chrysler through its restructuring, bankruptcy, and transaction. During the late 2000s, I was asked by several lenders to assist them with CCRCs and skilled nursing facilities. And that was really my introduction into healthcare. About 2010, my partner, Haywood Miller and I in DC decided to really focus our careers on healthcare. And so we spent about 5-6 years really building out a practice in healthcare. And by 2015, we decided we wanted to be on a bigger platform that had deep healthcare experience. And so we, along with 50 of our friends, came over to BRG specifically to work with BRG's healthcare platform, including people like Bill Orrell. And since then, we've done hundreds of healthcare providers and several healthcare payors that are in some level of financial distress.
So yeah, let's get into the meat of our conversation then. I mean, what the heck is going on in healthcare right now? We've got inflation that's going on. Labor costs are up, whether it's from salary, contract labor, high orientation turnover, investment yields are down. How do you operate in today's market right now if you're a financial operator in a hospital?
So first, just to answer the first part of your question, what's going on in today's world, you're right. Labor is obviously the most significant part of the underperformance, the significant variable in the underperformance. Labor shortages continue to be an issue. Year over year, cost of labor increased again in 2022. And so the labor costs in 22 are about almost 30% higher than they were in 2019 pre-pandemic. Part of that is obviously driven by the switch from permanent employment to contract employment and the premium you were paying on contract employees, that premium's come down. In some markets, it's come down about 75% at the end of 2022 versus its peak in the end of 2021. But the cost of labor continues to increase at a pace higher than the cost of wages overall in the U.S. The cost of wages went up 4.5% year over year this month. The cost of hospital labor, though, has gone up 5.6%. So it continues to outpace the cost of overall wages. And that will be an issue that continues to play a role in managing your cost structure in hospitals throughout 2023. On top of that, you have this sort of what we call the divergent rebound in volumes, where volumes overall have not returned to pre-COVID volumes, and frankly, may never return to pre-COVID volumes. However, outpatient volumes have recovered. Outpatient volumes increased about 7.5% in 2022. And so there's this benefit to operators that are nimble enough to take advantage of that outpatient opportunity. And then we can explore each of these in how people address them. But I would just add one other element to all of this, and that is the capital markets. As you alluded to, Nick, there is a significant debt maturity wall coming over the next 4 years. Just in the next 3 years, through 2025, there's about $70 billion of bond debts maturing. In 2026, there's $300 billion of bond debts maturing. So there is this wave of need in financing coming in hospitals exactly at the point where the market has really tightened up on hospital financing. And so you can see that. How does that show itself? One of the ways it shows itself is just the level of distress you're seeing in hospital downgrades, right? They've doubled year over year. But you also see it in the M&A market, right? There's no one available to finance transactions. And so transactions in 21 and 22 in healthcare in general exploded. It went up almost 100% year over year versus 2020 and 2019. But within that healthcare M&A market, hospitals are still at 50% of the volume they were pre-COVID. And so if there's limitations on going to the market for financing, and there's limitations on going to a strategic or financial buyer to solve your capital problems, it means that there's going to be enormous stress on hospitals over the next several years.
So, Peter, I'm going to come back about what we do on a financial section in just a second, but you talked a little bit about how volumes as a whole are down, but outpatient volumes are up. And shifting over to Bill for a moment, Bill, a lot of our clients right now, if I'm an executive, I'm probably saying, I got this guy telling me my volumes are down, but that actually doesn't make sense because I feel like I'm busting at the seams operating in the hospital right now. So there seems to be a little bit of disconnect with that. Is that because I can't get the patients out? Is that why I'm feeling it? Or what's going on there?
Yeah, I think that's what we're seeing, Nick, is that there's a renewed focus in many of our clients on just patient throughput, getting them in and out of the ED, getting them in and out of the inpatient footprint. But to Peter's point, we are seeing a shift to more ambulatory and outpatient volume and procedures and testing than we've seen in the past. I was going to ask Peter, actually, our audience is primarily senior clinical leaders who are narrowly focused on patient throughput, patient care, and the rising cost of the labor it probably keeps them awake at night. What should they be thinking about, and how does your financing discussion, how does that impact day-to-day operations in an acute care hospital?
So a couple things. There's one of the things I'll give you talk in the first person. What we do when we go into hospitals is we first of all understand what their financial profile is, right? How much money do they have? How long can they fund operations with just the money they have? But then we do a really quick assessment using people like Bill Orrell to understand what the state of the operations are and what can be done in the very near term. And so one of the things that has become a real focus among hospitals as they emerge from the pandemic is, one, taking advantage of increasing their yield on their net patient service revenue. So back in the day, people looked at their yield and net patient service revenue as, look, if I'm within 3 or 4 percentage points of where I was last year, I'm within striking distance. Now people look at their yield on net patient service revenue in decimal places. If I was 18.2% yield last year, I want to be 18.5% this year, because that money, that increase in yield, effectively collecting more of your revenue, goes straight to the bottom line. And that's the money that will help fund your operational improvement. And from the operational improvement side, you already hit on average length of stay. That's got to be one of the single biggest opportunities for us as we go into hospitals. And some of that is very near term, right? Some of that is improving the throughput in the hospital, improving your staffing and scheduling, and to improve near-term labor costs, and just creating much more efficient throughput in the hospital. They bring down your average length of stay. But some of it's longer term, right? Some of it is you need to develop your own pipeline. And you can see this in systems both large and small are now developing, for instance, their own CNA education system. They're qualifying their own CNAs so that they have at least a first right of refusal to pull in some labor to help relieve some of the stress on, and it's low cost labor to relieve some of the stress on their labor costs. Some of it is making sure that they have relationships with the local schools to make sure that they have a pipeline. And that means their own relationships for residency programs and teaching programs with the local institutions to make sure that they have nurses in their hospitals, so that the nurses have an affiliation with the hospital before they graduate. One of the things that we found is there's an incredible retention rate with nurses in systems that they're comfortable in. So if you are relatively competitive on wages, nurses don't want to change hospital systems. And so they take advantage of that by bringing nurses in during their education period so that they gain some affiliation with the hospital and hopefully migrate to the hospital post-graduation.
Yeah. And Peter, a couple other things, a couple other levers that we are encouraging some of our clients to pull around nursing retention is, one, really look at the day-to-day challenges of the bedside nurse and what we call non-nursing tasks that they take on over time as things, processes and workflows become broken in hospitals. Materials management and pharmacy and EVS kind of workflows come to mind that nursing just takes on. And it's a huge dissatisfier for the bedside nurse that affects that retention rate. And the other lever that we are working with our clients to pull is really investing in that nurse manager role. From our perspective, that's the front line of addressing your retention. And when you have a well-trained frontline nursing leader that the staff feels like is invested in them and has their back and supports them, it really does. And we've seen it in many clients. It really does affect the turnover rate and decreases it when they have a frontline leader that's all in for them.
Yeah. Just to add to that, one of the things that is rewarding about working with hospitals is there is a direct relationship between quality of care and profitable operations. So if you can, for instance, add or change your care model to the extent that you can take non-clinical tasks that nurses were previously doing and train other people to do those tasks. You talked about food, you talked about some of the other materials management, some of those other roles. And that's where, like, bringing in your CNAs, building up your CNA team is really helpful, where you allow the nurses to focus on the things that are really important for them to focus on. That reduces costs because you have lower costs labor doing the more menial tasks, and it improves quality because then the nurses are focused on the things that really impact patient care.
So, Peter, the public health emergency declaration for COVID is ending in early May, meaning that certain coverage flexibilities for Medicare, Medicaid, and even private insurance is going to be ending. I'm just wondering from your side, with the financial lens on, what should hospitals be looking out for as this emergency is ending? How does that come into this complexity of the market that we're already experiencing with this financial squeeze, so to speak?
Yeah, it's in some ways a part of a larger conversation just on your relationships with your payers and programs. But you start with, look, there is going to be a fall off from the Medicaid rolls, a material fall off when in May when the health emergency ends. So first and foremost, your front end has to be super aware of it, and you need to be working to requalify people very quickly. You need to be able to make sure that people that fall off that you can requalify, even in some form, you take advantage of. That you have to be prepared for that today, so that process is in place in May. It should be something that people do in any case, right? It's just a part of your patient access program, but it really needs to be something that you double down on now as the health emergency comes to an end. But it also shows that you really need to be thoughtful about your relationships and with whom you are contracting with payors. And one of the things that, a massive change in a paradigm shift in how people are reimbursed is obviously the growth in Medicare Advantage, right? And you need to be very aggressive in your growth and enrollment under Medicare Advantage. It is not just a regional issue anymore, right? There were the front adopters of the Medicare Advantage programs, the Massachusetts, Florida, California. It is penetrating all across the US now. And so that has to be a focus for your managed care program within the hospital.
Peter, a few months ago, there was a story in the news regarding a nursing contract renegotiation. In the story, nurses negotiated a 19% pay raise over 3 years, plus an addition of some guaranteed nurse to patient ratios that essentially equate to 170 additional nursing positions at just one of the hospitals. So you're the finance guy in this hospital with this number squeeze that's coming in. How do you operate in that environment, given all the other complexities that's going on right now with the financial squeeze you're describing?
So it becomes a part of a larger conversation, is to strategically, what should the hospital be in the future? And part of that is taking advantage of the reimbursement opportunities that are there for you between, like I said, Medicare Advantage, managed Medicaid, and the special opportunities, right? Being a part of value-based care programs, tying into accountable care organizations, making sure that you are taking advantage of all the opportunities to increase your reimbursement. But it also changes what you become in a hospital. And hospitals need to be, first of all, the underlying premise has to be, I need to maintain the continuity of care in my community. And what is the best way for me to do that? And part of that means I need to understand really what my population health demographic looks like. Where can I best serve my community? And where do I no longer need to invest as heavily in my community? One of the things that got upside down on over the last 5 to 10 years was this surge in ambulatory surgery centers, right? Hospitals assumed that part of population health meant that they needed to be in control of all the avenues for health care provision in their community. But what it really means is I need to make sure that I have the relationships with all of the providers in my population such that I'm pulling into my hospital system the people that really need my level of care, my acuity level of care, and that I have reciprocal relationships with people that allow my patients to be discharged out into the other healthcare providers, the subacute providers, for instance. And so it really means building a much more dynamic model in the community than previously we've had, right? When I grew up, hospitals were what we called cradle to grave, right? Everything that you had a healthcare need for, you went to the hospital. But hospitals now need to be much more nimble and deliberate about the care they're providing and making sure they're marrying with the other providers out there in a symbiotic relationship that benefits all of the healthcare providers in the community.
And so, Bill, what are some examples of those symbiotic relationships that Peter is talking about? I know for a nurse executive, primarily we're talking about what's in the hospital, but how can I leverage, or how can a nurse executive leverage some of those opportunities within a health system, whether that be internally as a system opportunity or with strategic partners?
Yeah, I think, Nick, we're seeing more of that. And we're seeing many more of our clients move to that hospital at home model where care is moving outside the four walls of the hospital. And how can we take care of patients better in the home? I think that's a developing model. We've not seen a whole lot of very successful ones just yet, but I think that's on the near horizon. We've seen, and I actually was going to ask Peter about this too. We're starting to see more health systems. Um, it's almost like they're supplementing their traditional patient revenue with other revenue streams. There are health systems that are getting into the healthcare consulting business now, which is interesting, and even partnering with technology firms in some cases. So it's interesting to see some of the models that are evolving as these health systems look for ways to supplement their traditional kind of inpatient revenue.
Yeah. And just to add on to that, you're absolutely right. Hospitals are looking to supplement the revenue. And I think there's areas where they've been really successful, like developing retail pharmacy, which with the nonprofit hospitals is double benefit, right? Because you'll get a 340B bump from your Medicare patients who go through the pharmacy. But you'll also get incremental revenue from being a retail pharmacy and establishing relationships, not just with the hospital physicians, but with the physicians in the community with whom you have a symbiotic relationship. And so that is one successful avenue. I do think that that I caution hospitals to remember their core responsibility, and that is to deliver patient care for the higher acuity patient needs. I found that hospitals tend to be less successful when they build out other operations, including in doing things I already mentioned, ASCs, but even in doing things in subacute and psych, that they've been less successful because the way their care delivery model is different. And so to manage a care delivery model like a subacute or a psych, you really need someone that's an expert in managing those businesses. And at least my recommendation is you're better off partnering with someone in a way that allows you to bring in an expert to run those facilities, but having a relationship that relieves the pressure on the hospital and the hospital's volumes, but also provides, for instance, having relationships with FQHCs or front end clinics that relieve the pressure on the ED. Those are opportunities where hospitals can relieve some of the lower acuity, but cost intensive operations and allow the hospital to focus on the things that the hospital should be focusing on.
The first quarter just recently ended. Hospitals are seeing the most first quarter defaults since 2011. Wow, that's staggering. We're anticipating that there's going to be more defaults later this year, just with the squeeze that you're talking about. Peter, if I'm a nurse executive in a hospital and you're coming into my facility, what are the top 2 or 3 things that you need from me to help you be successful, which ultimately helps the hospital stay open?
Right. The hospital staying open is the primary goal. Like continuity care is really what we're all about, right? So look, first of all, the data is immensely valuable, right? Can't diagnose the patient without the right data. So ensuring that we have the right data from the patient floor, right? From the med-surg floor, for instance, making sure we understand that we can do the root cause analysis. Why do we have a buildup in length of stay, for instance? And then lastly, people really need to rethink and be open to rethinking exactly how those things are run and how we're providing care. And making sure, you talked about defaults. One of the underlying causes of defaults is the fact that bad debt at hospitals has almost doubled since 2019. And part of that is making sure that the documentation and the management, the flow of management of care is tied in with the front end and the back end of the hospital. And that requires the cooperation of the nurses on the floor.
For all of our clients, I think labor costs and length of stay are at the top of their mind. How that affects the overall financial picture of a health system. That's exactly what we wanted to talk about. So I think we hit that on a couple different fronts.
Excellent. Peter, I'll let you wrap it up with any closing thoughts you might have.
Look, I think it's going to be a tense 2023 through 2025. And despite the best efforts of everyone, we will focus as a team here at BRG on all the levers that we know to pull to ensure continuity of care. But ultimately, the ultimate determinant is, does the government change the way they require care to be performed? For instance, setting staffing ratios, specific staffing ratios, or does the government allow more flexibility in the way of care? Does the government address reimbursement in a way that is more tied to what's going on in the market real time? For the lag in the change in reimbursement in Medicare rates is about 18 months. So when your costs went up 30% at a hospital in 2021 through mid 2022, you were getting a 3% increase in reimbursement rate. And so there's lots of things that the government can do to either hinder the hospital's ability to transition to the current market dynamics or facilitate the hospital's transition. And I think that will be, frankly, the biggest question over the next 3 years.
And Bill, same question for you. Any closing thoughts?
I think that, to Peter's point, this is just an interesting time. I think it requires nursing leaders to be nimble. I think we're starting to see many of them doing some innovative things to deal with the staffing and patient care challenges that they have. I think it's going to require, like Peter said, over the next couple of years, we're not going to be able to do things the way we did them in 2019. So it's requiring a whole new perspective and mindset to provide patient care, but with the ultimate goal of keeping hospital doors open and serving the communities that we're in.
Peter, Bill, thank you so much for your time today. I appreciate it, as well as our listeners, and look forward to continuing to right the ship and keep things stable in 2023.
Thanks, Peter.
Thanks, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.